The World Health Organization declared Mpox a public health emergency of international concern on August 14, 2024, amid a growing number of cases in the Democratic Republic of Congo and other countries. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Jean Nachega, an associate professor of infectious diseases and microbiology and of epidemiology at the University of Pittsburgh School of Public Health and a professor of medicine at Stellenbosch University in South Africa. Dr. Nachega has co-authored a perspective article about Mpox in pregnancy. Dr. Nachega, what's the state of the current Mpox outbreak? How many cases have been reported and in what countries?
The Mpox currently is out of control in Africa, mostly in Central Africa. The Democratic Republic of Congo, it's the epicenter of this outbreak. The place where the Mpox was in human was discovered in 1970 in a young boy, 9 months, in the Basankusu province in Democratic Republic of Congo. Nearly 70% of about 8,000 Mpox cases notified by the World Health Organization, by the DRC Ministry of Health from January to May 2024 did happen among patients less than 15 years. So which included about 300, which is about 80% of all deaths. So this is the highest mortality actually is among infants less than 1 year, which is a threefold higher than in those with young adults. And the issue is that significant knowledge still remains about the epidemiology, transmission dynamics, genomic diversity, and natural history, especially the impact of the different clade strain of the virus.
In fact, how is the form of the virus that's causing this outbreak different from the one that led to the global outbreak in 2022?
So basically, we have two types of strain. Historically, the clade 1 from the Congo Basin in Democratic Republic of Congo and the clade 2 mostly from West Africa. So clade 1 is the more lethal with mortality up to 10%, and clade 2 used to be less lethal, mortality less 3%. So the current outbreak, our research collaborative group in DRC with Professor Jean-Jacques Muyembe, we identify a new lineage, which we are calling now, we name it 1B. This is the one that caused outbreak in a mining town of Kamituga in South Kivu, Eastern DRC. And it is ongoing, is spreading in neighboring country of Rwanda, Uganda, Kenya, Burundi, and there have been cases identified even outside of Africa in Sweden. So this is really worrisome because clade 1, usually it's more lethal. In contrast with the 2022 global outbreak in US and in Europe, among mostly men who have sex with men, the mortality was less than 1%. So this, we're talking about more virulent clade, which is also more transmittable.
And how much progress has been made on a vaccination campaign to address this outbreak?
So the vaccination campaign is ongoing. This is just happening now as more donation is getting to the country who need them. So the Democratic Republic of Congo, they received their first 200,000 doses of the Bavaria Nordic vaccine. But this is just the beginning. DRC needs about 10 million doses to control its outbreak. So we still long way to go to really get to where they should be in terms of access to vaccine. And this is a vaccine that was used for smallpox eradication because of the virus that caused smallpox belong the same family as the monkeypox virus. So there is some cross immunity which make the vaccine also effective. The problem is the time is not on our side. The virus circulating already beyond DRC is there, it's out there. So we may have missed the opportunity really to stop this before it become another global outbreak. So it's kind of the history repeating itself. We had COVID and then now we have Mpox. Obviously, it's not yet at the scale of COVID, hopefully not. But it's a scary virus when you see how stigmatizing, once you get it, you have all the skin lesions, which are really highly stigmatizing. It's terrible. And children have about 10% mortality or even higher. The painful part is that it also happening in the continent where the health system is very fragile. There is no access to vaccine and therapeutics the way it could have been was mobilized in Europe and US.
Your article focuses specifically on the risks of Mpox in pregnancy. So, what's known about the effects of Mpox on pregnant people and fetuses?
So there is not much. We're still trying to really do the proper research to try to understand. The information regarding the effect of monkeypox infection in pregnant is very scarce. Vertical transmission has been associated with fetal demise and congenital infection. By analogy, smallpox infection, the disease is expected to be more severe in pregnant women than in healthy individuals who are not pregnant, particularly during their third trimester. We have some historical data just to cite a few. There was a paper in 2006 by Niaura showing really overall case fatality of about 34%, really high during last trimester of gestation in the smallpox era. The risk of death among pregnant women in two outbreaks was 2 to 4 times higher than in non-pregnant women, and miscarriage and preterm birth with smallpox was estimated to about 40%. Even mild cases were associated with miscarriage and premature birth. Prior smallpox vaccine was not associated with protection against adverse events. So the morbidity and mortality of Mpox in pregnancy is quite significant.
Are existing Mpox vaccines thought to be safe in pregnancy?
We don't know. That's the quick answer. We need to conduct the proper research to evaluate. The current smallpox-based vaccine still need to go through a rigorous evaluation assessment, their effectiveness and safety in pregnancy. Our research collaborative group is trying to secure funding from NIH to try to conduct such study in the Democratic Republic of Congo, where the epicenter of the epidemic is currently happening.
Beyond increased availability of the vaccine, what steps should countries and the international community be taking to stop the spread of this outbreak?
Thank you for asking that question. The international community should really come in solidarity and support to the country where the epidemic is raging, starting by DRC. Without controlling this epidemic in DRC, all the region, Africa and the world is at risk of another global outbreak as we experienced in 2022, but with a less lethal strain. We need also to really, at the African level, African government should also invest in not only procuring the vaccine, facilitating regulatory aspect, but also try to speed from what we learned from the COVID era, speed up work to manufacture vaccine on the continent. mRNA vaccine technology, it's been really an eye-opener during COVID era. There have been some hubs since then created that were built in Africa. We need to build on those mRNA vaccine hubs to try to also plan for Mpox vaccine.
And finally, in a related perspective article, Gostin and colleagues write that endemic Mpox, the current outbreak, has not garnered the same attention and the same investment as the global outbreak in 2022 did. So what can be done to address that disparity?
We need to really work hard to create and to try to stimulate through advocacy, raise awareness, and to try to build the same energy that did follow the 2022 global outbreak in terms of speeding access to medical countermeasure like the diagnostics, therapeutics, and vaccine. Because so far, in terms of therapeutics, we still don't know an effective treatment. The recent NIH study evaluating tecovirimat in Democratic Republic of Congo, the PALM-007, did not meet its primary endpoint of efficacy, while there's still other trials going on in US, Canada, UK, and Brazil. We definitely need urgent alternative treatment to be evaluated.
Thank you, Dr. Nachega.